of our own tumors. And these profiles help predict our potential for reoccurrence or metastatic disease. They also improve our survival by helping us select the best treatments and for us by improving our quality of life and sparing us from toxic treatments that may not be of any benefit. So as Laura said, we are heading into a time where our biology will trump staging. Yeah, as Laura said. Laura Rex. So as an advocate, I'd like to make a few points. I spent the last week just poring over all the research on prognostic biomarkers and realized I was way over my head. But the research into biomarkers is escalating at an amazing rate. We hear in lectures and conferences all the time about tumor suppressor genes and oncogenes and mutations and transcription factors and all the complex network of proteins in the signaling pathways, subway systems. And all these sound really exciting and overwhelming at the same time. So as an advocate, I hope that this biomarker research translates into useful and valid clinical applications. So, and I would like to see the development of biomarker assays and new therapies sort of made in tandem, which is, I think, what the I-SPY 2 trial is trying to do. So that we can get faster, better drugs into the pipeline. So the more I looked at the information on biomarker data, the more I read about the need to expand and encourage adoption of guidelines for the publication of biomarker study results. So not actual tests, but the studies. And my fellow advocate there, Linda Vincent, brought this to my attention. So this effort has been taken up by many groups, but such as the National Cancer Institute and the European Organization for Research in the Treatment of Cancer, at international meetings on cancer diagnostics. And they produced the REMARK guideline, which stands for Reporting Recommendations for Tumor Marker Prognostic Studies. So the REMARK addresses reporting of study design, hypothesis, patient and specimen characteristics, assay methods, and statistical analysis methods used in all studies of biomarkers. So if everyone followed the same reporting guidelines, it would allow researchers to independently derive conclusions regarding validity and levels of evidence and avoid research that may have already been found to be fruitless. And I was hoping Dr. Gray could be here to comment on that, but maybe Dolores can. But I also believe that research on biomarkers must be conducted in an environment of social responsibility, and in which resources are shared as part of a social network. I do grant reviewing for the Department of Defense, so I know how many of you are out there competing for very few dollars. So with limitations on the critical resources, such as biological specimens and funding, resources need to be shared and part of the network. So we need to have collaboration among professionals with diverse perspectives, skills, and training. And we need to accelerate the process in combating a disease as complex as breast cancer. So by working together with academia, industry, government funding, and patient and consumer advocates, we can create an environment of socially responsible research that fosters a collaborative approach to investigating breast cancer. And I think the I-SPY 2 trial just that. I mean, Laura mentioned the, was it 20 or 21, other research, but she didn't mention, I don't know how many hundreds of or more people are actually involved in collaborating from all over the country, probably in the world, on I-SPY 2. So, yay. Yeah. It's about time. So, and then finally, in my dreams, I would love to see predictive biomarker research into prevention trials. I don't know if that's possible, but I think, is it possible? I mean, we need to look at the effects of lifestyle and the environment exposures on the potential development of cancer. For example, a young woman with a certain genetic risk for breast cancer might be encouraged to have her children at a younger age. Or in spite of a genetic predisposition or somebody already diagnosed with breast cancer, they might continue their harmful lifestyles, whereas others might change their lifestyle with diet or exercise. So a prevention trial such as this, much like the Women's Health Initiative, would require a research infrastructure that prospectively recruits healthy people and patients with cancer and repeatedly looks at lifestyle and environmental factors and collects biological specimens. So we can discover early detection biomarkers that could identify a woman with a cancer risk, then that woman could make changes in their life before they were diagnosed with cancer. So I'd love to see some of those. I had some questions if everybody else had questions. About 2 minutes.
Well, I think it's an excellent perspective.
I have a question that's probably going to go on forever, but you have patients that do well and patients that do poorly. Or the patients that do poorly, you have interval cancers and you have tumors that don't respond to therapy. Do you have any sense, and probably the answer is all of the above, but do you have any sense of what the major problem in the system is now? Do we need a different type of screening to catch the interval cancers? Did you just not see the interval cancers because they don't show up on the screens? And if you caught them early enough, they would respond to the conventional chemotherapies and life would be pretty.
No, we know the answer to that. The biology is just different. These are different. It's, that's the point I'm trying to make. Is early detection is not the answer for certain kinds of tumors, and that's the issue. And do we know what the answer is? If we knew the answer, we wouldn't be doing I-SPY 2. And we're testing a bunch of different.
I think still somewhat. So if you take like the BRCA1 carrier as an example, so we know that women who carry a BRCA1 germline mutation have a higher likelihood to develop a more aggressive cancer.
Right.
So based on that, the screening interval is already shortened to 6 months. And so we do know, and so therefore, although they will get more aggressive cancers that otherwise would be more likely to turn up as interval cancers, by shortening the screening interval, you capture even those tumors at an earlier stage. But of course, it's only a small proportion. So now, how about all the rest who is not a BRCA1 or 2 carrier? Can we identify in that population women who also, when they're still healthy, have a higher risk to develop a high-risk cancer? So there are some ideas to be able to identify them. So I think then you would eventually be able to capture or to find those tumors in an earlier stage. Yet, because the nature of the biology of those tumors is more aggressive to begin with, they would still have at least for a certain proportion of them, have a lower likelihood to respond to conventional chemotherapy. But if we then superimpose our biology knowledge on that, we can maybe target specific pathways to help to prevent recurrence of the disease.
So every drug in
I-SPY
I-SPY
is
is
I was
an
asking
idea.
is slightly, I mean, you're getting there. I was thinking not that you would screen more frequently, but there would be yet a whole new kind of screen that might pick these things up.
But that's the point. I think the point is that there are some cancers that you might understand how to prevent. It's like who's at risk for what kind of cancer. And one of the things that we're trying to do is like, well, who's at risk for these cancers that don't respond, and what do we know about that? If we know what treatments, for example, so if you from I-SPY learned that there are, I don't know, or something, everyone knows, MYC inhibitors or something that work in combination with chemotherapy, but then maybe you figure out that you can identify something that tells you who these people are that get it, you can then do some targeted interventions, and maybe it would be that drug alone or something you do once a year that, that's the idea. You ask, how are we going to get to targeted intervention? That's the kind of idea, that's the kind of thing that you might have. But first you have to understand who's at risk for what kind of cancer, and then come up with some strategies that help you sort out, who those people are, and then you can test some different kinds of interventions. For prevention, we can't do it now because we don't even know who's at risk for it. We don't know yet what's going to cure them. But I would suggest that even our very, very sensitive screening technologies aren't necessarily going to be the answer unless we understand.
But I think your question is also, do we need other screening modalities.
Yeah, that's
And yes,
sort of more